السلام عليكم ورحمة الله وبركاته. مساء الخير جميعا. أتمنى الصوت واضح.
واضح دكتور.
حياكم الله. مساء الخير جميعا. إن شاء الله اليوم هو اليوم الرابع في كورس Oncology, Therapeutics in Oncology for Pharmacy students. Inshallah, today we have three interesting topics, all of them non-solid tumors. We have acute leukemia, which will be presented by Dr. Hadif Samarkandi, and the second topic will be chronic leukemia, which will be presented by Dr. Abdullah Rajhi, and the last topic, which is lymphoma, and will be presented by Dr. Aisha Al-Azmi. So our first speaker is Dr. Hadil Samarkandi. She is a board-certified oncology pharmacist in King Faisal Specialized Hospital and Research Center. Let's welcome Dr. Hadil, and you can start.
Assalamu alaikum everyone. Hopefully I'll make it, inshallah, within the designated time. I'll be talking today about acute leukemia, so I'll be sharing the acute leukemias. Hopefully I'll finish it within the time. So to begin with, leukemia are heterogeneous group of disease or malignancies, as we call it, characterized by unregulated proliferation of the blood-forming cells in the bone marrow. They usually come as a blast, which is known immature leukemia cell, and they are characterized by crowding up, which means they crowd in the bone marrow, and they prevent the normal function of the bone marrow itself, along with dysfunction production of cells. If you wanted to talk generally about it, so more than 90% of the cases usually occur as leukemia, as acute and chronic in the adults. The AML mainly, we call it as an elderly disease, and the ALL is more commonly in pediatric disease. Leukemia is also the leading cause of cancer-related deaths in persons younger than 20 years. And acute leukemia actually is the most common malignancy in persons younger than 20 years, accounting for around 26% of all childhood malignancies. Now, if you wanted to look at the causes of acute leukemia, there is no known cause until now or identified. They believe that the exposure to certain factors lead to the destruction of the normal DNA or the process of healing of the body cells, including ionization or radiation. Aging, it means that the body cannot perform properly as it used to be, or recovering DNA as it used to be. Gender, they believe that males have more risk of developing malignancies compared to females. Certain kind drugs and chemicals, which we will discuss, and genetic condition is not very strongly associated. However, if multiple persons from the same family have cancer, it might be genetically inherited. So a general look, so we can understand what do we mean by myeloid lymphoid leukemia. So the progenitor cells, or the pluripotent stem, which is the mother cell, usually presents in the bone marrow. It will be separated still in the bone marrow to give us myeloid stem cells and lymphoid. Now, the lymphoid is responsible on the production of T cells, B cells, lymphocytes in general, and the myeloid responsible for production of eosinophil, neutrophil, platelet, erythrocyte, basically, which gives whatever we see in the CBC or complete blood count in the lab. As in for the pathophysiology of the disease itself, they believe that the single leukemic cell acquires mutation. So when a cell that comes from the bone marrow is mutated, it means the whole segregation of the production for that subsection is defected. They also believe that failure to maintain the balance between cell proliferation and differentiation, which, as we said, give the crowding out. As you can see from the picture, this is the look of a healthy bone marrow, and this is a bone marrow filled with leukemia. Now, how does it occur? Now, leukemia cells have a growth and survival advantages over normal cell. So typically, when a cell starts to produce the genetic material, uh, if they stop at certain points to check and recheck to correct, and if a cell is defected, it usually leads to the death or apoptosis of that cell. However, in order for a cancerous cell to grow and to thrive, it needs to go over a certain process. So we have here what we call proto-oncogene, in which the production of genes that produces or lead to the growth or production of cancerous cell, followed by loss of signals from the blood cells to differentiate. It means the normal cells cannot recognize, or actually the cancerous cells cannot recognize that there is something wrong with the cell. They lose the ability to correct it, stop it, and to eliminate it. Also, we have against the proto-oncogene what we call tumor suppressor genes. These genes are responsible for stopping and killing whatever this defected cells have produced, and loss of signals for apoptosis. So that's why we hear a lot that cancerous cells might be immortal, in which they accept or they acquire a characteristic that inhibit or prevent them from death and cell lysis. Usually, clinical presentation between all leukemias come in the same presentation. Although, if we looked at the lymphoid, as we discussed part, it only affects lymphocyte. However, due to the crowding part in the bone marrow, it prevents the normal cells from functioning in a proper way. So usually patients present with fatigue, anemia due to reduction in the hemoglobin production. They also present with bruising, petechia, or bleeding due to thrombocytopenia and dysfunction in the platelet. They also present with fever, chills, or rigors, giving that they might have acquired infection, giving the presence of dysfunctional neutrophil and white blood cells, or even the lymphocyte. This is as signs and symptoms. If we wanted to look at the patient panel, when we take a blood sample, we're going to see anemia, in which the hemoglobin will be less than 70. It also presented as normochromic normocytic, which means it's not affected by the deficiency of folic, iron, or vitamin B. Patients also will present with thrombocytopenia. They also will present with either leukopenia or leukocytosis, depending on the disease itself. So if you can see that ALL, not the majority, will say that 50% of the patient will present with acute lymphoblastic leukemia with high count, while patient with acute myeloid leukemia will present with low count. We also will have a uric acid elevation, which basically because of the overproduction of the cells and the overgrowth. Electrolyte disturbance, this is one of the features or the complications associated with the presence of overreactive or overproduction of cells, in which the breaking down of the cells will lead to the release of both uric acid and electrolyte. Coagulation or coagulopathy, this is seen in particular with acute myeloid leukemia, and a subset of it, which is called APL, we'll be discussing in a bit. So for diagnosis, once we see the patient laboratory profile, which means complete blood count and differential, we can detect the presence of blast in the peripheral if it was overproduced. Then we need to do the bone marrow biopsy, in which we take a biopsy from the bone marrow and we run a couple of tests on them. One of them called immunophenotypic, in which we see the antigen presented on the cell surface. This tells me which type of leukemia I'm dealing with, whether it's acute myeloid or acute lymphoid. And even when I look at myeloid or lymphoid, I'll be looking at subset and differentiating between T cell, B cell, or the 7 subtypes of the acute myeloid. We also look at cytogenetics, which basically, if I wanted to look at the cell from the outside, I'm checking the correction of the chromosomes in there. So is it an abnormal chromosome? Has been there any deletion addition, translocation. And we also look at molecular testing, in which we try to identify any new mutation of genes or new production of genes. We also take a lumbar puncture, which we assess the CSF or the cerebrospinal fluid to see if there is a CNS involvement or not, which will classify the disease, whether it's high risk, low risk. We'll be starting with the first one, which is acute myeloid leukemia, usually diagnosed with a peripheral blast greater than or equal to 20%. Also, by the WHO, they diagnose acute lymphoblastic leukemia, leukemia, in the presence of any of the following. So if we had, this is depending on cytogenetics. So after we take the bone marrow and we check it for cytogenetics and molecular. So if the patient had a translocation of 821, inversion 16, or translocation between chromosome 16 and 16, or translocation between chromosome 15 and 17, this is per definition called acute myeloid leukemia, which we call it core binding factor, regardless of the blast count. Now, with AML classification, it differs according to the translocation or recurrent genetic abnormality due to the features background of the disease, or whether it's induced by something else. So I'll be concentrating on the most important ones, at least. So if we're looking at acute myeloid with recurrent genetic abnormalities, the best favorable, as we said ETO, which is 821 translocation, we can see that one of the favorable acute myeloid leukemia we'll be discussing in a bit, acute promyocytic leukemia, which is mainly translocation of 1517. And if a patient had acute myeloid leukemia with myelodysplastic related changes, or what we called MDS, and therapy related. So this arises from the use of alkylating agents or topoisomerase 2 inhibitors. Now, if we wanted to look at the prognostic factor to know whether the patient is going to do good or bad, we will be looking at several factors. First, which is patient-specific factor. So if a patient is elderly or above the age of 60, they usually have decreased overall survival because they cannot tolerate intensive chemotherapy. We also look at performance status comorbidities, giving that we're giving intensive chemotherapy, and this chemotherapy is associated with severe toxicities. Total white blood count at diagnosis. So they consider the higher the count, the worse the prognosis, and the presence of extramedullary disease. It means a disease outside the bone marrow. It involves somewhere else, including the CNS. We also look at the response once we give the therapy. So if the patient responded and went into remission, it means this is an excellent prognosis. If the patient did not respond and needed another salvage, this might be a poor prognosis. And the duration of that response also reflect on the patient. So stratifying the patient according to the prognostic factors will lead or will guide us through the therapy. So if I wanted to classify a patient, favorable, intermediate, and unfavorable. So unfavorable, we look at cytogenetics, which is the chromosome picture in the cells, and genetic mutations with the presence of acute myeloid. So as we said, core binding factors are favorable, and the presence of MPM1 mutation, as well as SEPA. These indicates that this kind of patient will more likely respond to chemotherapy and will have a good prognosis. As for the intermediate, any patient that have normal cytogenetics without any translocation and without any deletion or inversion. If we wanted to look at genetic mutation, patients with translocation 821 or inversion 16 in the presence of c-KIT mutation, also FLT3, which we'll be discussing in a bit. So unfavorable, so FLT3, just to make a point, it's intermediate in the presence, FLT3 mutation, in the presence of MPM1. This is the only time we say this is an intermediate. However, if we had a FLT3 mutation as a genetic mutation present alone without the MPM1, this automatically transfers the patient into unfavorable risk group. As for the cytogenetics, any deletion of 5 or 7 chromosome leads to putting the patient in the unfavorable risk. And also the poorest risk amongst all is the presence of MLL gene, which is infantile chromosome usually present only in infants and should disappear in elderly. As for the treatment, so we have a short-term goal therapy and long-term. Our short-term is to achieve a complete clinical and hematological remission, in which we're aiming to disappearance of all the blast in circulation as well as in the bone marrow, and resolution of normal hematopoiesis. This is the main goal, to restore the patient white count function, platelet count function, hemoglobin function. And for the long term, we want to maintain the patient NCR and prevent or delay relapse as much as possible. So if you wanted to look at the treatment phases, we have to give patient induction, which aims at putting the patient in remission, followed by consolidation. The consolidation is to maintain this remission I have put the patient through. This might include the use of chemotherapy, like in favorable risk, and it might include hematopoietic stem cell transplant as in patient with unfavorable risk. Now, looking at the induction chemotherapy, as we said, elderly usually or patients who are above the age of 60 cannot tolerate intensive chemotherapy. Therefore, we divided the patient into patients with a lower age, below than 60, and above the age of 60, or the presence of comorbidities, even if the patients are young. So I'll come to this case. So I'll just test your knowledge. We can go through the treatment. So it says that RO is an otherwise healthy 52-year-old female with no prior medical history who was admitted to the hospital because of a peripheral smear that consisted with acute myeloid leukemia and without a suggestion of APL. So the patient does not have an APL. It's acute myeloid. Bone marrow biopsy evaluation confirmed AML with cytogenetics demonstrating de novo favorable risk. So they classify the patient as not induced by any other agent, so acute myeloid leukemia with favorable risk, and CD33 is negative. Which of the following treatment is best used as a remission of induction therapy to treat the patient? You can choose one of the following. So is it the combination of tretinoin with arsenic? Is it 7+3 with daunorubicin high dose 90 milligram per meter square per day? Or is it hyper-CVAT or liposomal cytarabine and daunorubicin? I think we can conclude the answer. So good. At least the majority answered correct, which is 7+3, the use of daunorubicin with higher dose. So when we want to look at a patient with remission induction with younger age that can tolerate intensive chemotherapy, the most active single agent in acute myeloid leukemia is anthracycline and the anti-metabolite cytarabine, at which we use it as an intensive chemotherapy for treating such patients. Now, the typical regimen used, I'm not going to go over them. I'm going to use going to discuss the most common one, which is 7+3. It stands for 7 days of cytarabine, along with 3 days of idarubicin or daunorubicin, which is anthracycline at the end of the day. According to whatever molecular genetics or mutation we have, the patient will be treated. So as we spoke in a bit earlier, if a patient had genetic mutation such as FLT3, there is a medication called midostaurin that targets this, which is a tyrosine kinase inhibitor that targets that mutation. It has proven to improve overall survival in such patients. We also use a new combination that was recently approved. It's called daunorubicin cytarabine. It is used mainly for patients with secondary or let's say therapy-induced acute myeloid leukemia or patients with MDS background. We also have the anti-CD33, which is gemtuzumab. We can use it as a part of the induction chemotherapy for newly diagnosed acute myeloid leukemia patients. And it also has been proven to improve overall survival in favorable risk. That's why we prefer using it in such patients, in which those kind of patients will not go further for a transplant. Now, coming to elderly patients who are not fit for chemotherapy, those with performance status poor, or they have comorbidities such as cardiac dysfunction or whatever, we usually try to avoid 7+3 because Anthracycline will lead to cardiac toxicity and decreased cardiac dysfunction. And cytarabine, those kind of patients, we have to know that these kind of patients will stay in a neutropenia for a long period of time. So if a patient has comorbidities, not fit, we might actually kill them if we gave them 7+3. So low intensity is recommended in such patients, in which we have benefit in event-free survival and overall survival compared to best supportive care. It also reduces this prolonged cytopenias as discussed. We can give it in the ambulatory settings. It also can be used in the newly diagnosed patient as well as in the salvage therapy if the patient does not have any other line of therapy to be used. But the disadvantages, it needs around 3 to 4 cycles to achieve remission. These kind of agents, methylating agents such as clofurapine or low-dose cytarabine, we can also use decitabine. This medication, which is called venetoclax, it's a selective molecule that inhibits BCL2, has gained a lot of popularity recently in such patients, in which they have proven an excellent outcome in patients who cannot tolerate intensive chemotherapy if we combined it with low-dose cytarabine or with azacitidine. Now, if we wanted to assess once we give the patient the induction in the aim of going through remission, we take a bone marrow biopsy at day 14. If the patient is in remission, we continue or we go forward after 1 month or after recovery to consolidation. If not, patient might need salvage therapy. And in order for us to say that the patient went into complete remission, it means that we restore our normal hematobiosis, normal white count, ANC recovery, and absolute neutrophil more than 1,000, and the presence or the absence of bone marrow blast or the identification less than 5%. For the remission consolidation, if I wanted to maintain the patient on remission, the standard of care is to use high-dose cytarabine. To keep in mind, the most common side effect associated with high-dose cytarabine is ocular toxicity, namely conjunctivitis, and it can lead to cerebellum toxicity, and it can lead to cytarabine syndrome, in which the patient will have fever, rigors, resembles, and infection. Now, for the treatment of relapsed refractory in adults, usually associated with poorly prognostic patients who have poor prognosis, and the salvage requires intensive induction or re-induction chemotherapy if the patient is fit, and then the patient should go directly for a transplant. I'm not going to go through these agents. You can read them sometime else. These are agents that have been approved, which is targeted agents, oral medication that can be used in case the patient had genetic mutation, such as IDH2, IDH1, or even the FLT3 already patient have received midostaurin. One of the most important things to look at with patients with acute myeloid leukemia, especially with the induction, that these kind of patients at higher risk for invasive fungal infection. So we need pusaconazole, which is proven to improve overall survival, and antiviral for patients with herb zoster positive. Going to the second most common acute leukemia, which is acute promyelocytic leukemia. This is one of the favorable risk leukemia, in which curative leukemia. It happens due to the presence of translocation between chromosome 15 and 17 that leads to the production of what's called PML rara. Although this type of leukemia is curative and the best kind of leukemia, the death occurs within the first 3 weeks is very high due to the coagulopathy that happens with it. We identify the patient risk, or we stratify them according to their presentation with their white count. So they go directly to high risk if their white count was more than 10,000. So for the case, that's basically a newly diagnosed patient with APL. So what do you think is the best regimen treatment at this time? 7+3, midostaurin, tretinoin plus idarubicin arsenic, or arsenic trioxide? I think we can conclude for the sake of time. Excellent. So tretinoin, which is vitamin A, arsenic, and idarubicin. Now the idarubicin is given here because of the count, as we can see. So those patients treated with differentiating agent. Now this is the new recommendation. Upfront, we use targeted agent. Chemotherapy is added as needed. So we use tretinoin, which we call ATRA, and we use arsenic, which we call ATO. The combination is used until the patient achieves remission or up to 60 days. The most important toxicity seen with these agents, differentiation syndrome, in which the count of the patient will increase significantly in the beginning, in which patient might go into differentiation syndrome, and this might need to interrupt the therapy, support the patient. Those patients will might go into maintenance according to their risk stratification. Now, the APL, as we said, the differentiation syndrome occurs with the therapy, in which the count will increase significantly. This will be presented as an edema, dyspnea, or pulmonary infiltration, sometimes with acute renal failure. This is basically because of the cytokine storm released by the cells. Risk factor, usually, as we said, white count. So prophylaxis use is controversial. It might be given for patients with high risk, and the treatment is to interrupt the therapy in case it was severe and support the patient with dexamethasone. Last part of the presentation, acute lymphoblastic leukemia, in which it might present as a B lymphoplastic or T lymphoplastic. And we usually identify them by the cluster of differentiation or the cell antigen presenting on the cells. Now, ALL is one of the common leukemia that likes to hide in different places, in which we call it sanctuary sites, such as CNS and testis or ocular involvement. We prognose the patients according to the type of whether it's a B cell or T cell, with the age as well, and in the presence of certain cytogenetics. So if we looked at a patient with hyperdiploidy cytogenetics, this is considered favorable, while hypodiploidy unfavorable. As you can see, one of the mutations that are unfavorable is PCR-APL, or what we call Philadelphia chromosome. The presence of Philadelphia chromosome is indicator that this patient more likely to relapse and unresponsive to chemotherapy. And the translocation occurs between chromosome 9 and 22. These kind of patients will be receiving tyrosine kinase inhibitor that targets this mutation, and they will go most likely for transplant. Again, the goal of therapy with such patients is to achieve remission and to maintain it. The difference between acute myeloid leukemia and acute lymphoblastic leukemia, that the therapy for favorable risk patients, if we're not planning on a transplant, it's going to go for a long period of time, in which the patient will go for induction, followed by a consolidation and intensification according to the patient risk, followed by a maintenance, in which such patient will be maintained on chemotherapy for almost 2 years. Now, the treatment will be designed according to the patient age and the cytogenetics, as well as performance status. So the backbone of any chemotherapy used with acute lymphoblastic leukemia has to contain these three: anthracyclines, vincristine, and corticosteroid. Also, CNS prophylaxis is a must with such patient, because, as we said, most likely these kind of leukemia will be heading somewhere, and the relapse might come to us as isolated CNS relapse. Now, the pediatric have developed something, and the adult adapted it recently, the use of asparaginase, in which it has improved the outcome of ALL significantly. Dexamethasone, if we wanted to look at the difference between the use of different corticosteroid, we can use dexamethasone and prednisone. However, dexamethasone has a better penetration to the CNS, but keeping in mind it might be more toxic compared to prednisone. These are the kind of chemotherapies that can be used: hyper-CVAD or CLAC or Larsen regimen, ECOG, and different kind of regimen according to different hospitals. As we said, asparaginase have improved the outcome of acute lymphoblastic leukemia significantly. They can present in 3 different formula. regular E. coli driven, Erowina, which is synthesized, and pegylated E. coli asparaginase. The most common toxicity seen with such agent is allergic reaction, elevated liver function, and coagulopathy. Now, the management usually in such patients is supportive care as much as possible. Now, one thing we always keep in mind, if a patient developed allergic reaction to asparaginase or pegylated asparaginase, it means that the patient developed antibody and the patient might not be responsive anymore. And that is what we call subclinical hypersensitivity, in which antibodies can be developed without the knowing of the presence of these antibodies and without knowing that it's not effective anymore. That's why we need to monitor the level of asparagine and treat accordingly. CNS prophylaxis required, as we said. I'm not going to go through it extensively. Now, for the post-remission consolidation, also depends on the hospital protocol. However, asparaginase, high-dose cytarabine, and high-dose methotrexate, according to what we are treating, lymphoid or lymphoblastic, will be used for around 6 to 8 courses. As for the delayed intensification, we're almost using the same way, the same agents used in the induction, followed by different kind of agents as a maintenance, including 6-mercaptopurine and methotrexate. For this patient case, so this patient is a 26, presented with a translocation of 922, and this patient diagnosed to have Philadelphia chromosome. Which of the following you think will be suitable to use with this such patient? Is it tretinoin arsenic, blina, clofarabine, or hypercivad with dasatinib? We can conclude also for the sake of time. Okay, it's a tie, so we'll see in a bit. So if a patient had Philadelphia chromosome, as we said, it's a poor prognosis, these kind of patients will receive, according to the NCCN guideline, they will receive hypercivad and TKIs. There are different treatment methods, and I would say that not all hospitals use high intensive chemotherapy with TKI. Some of them use light chemotherapy with TKI until the patient achieves remission, and they take the patient directly to transplant. For the relapse refractory, again, according to the patient risk and according to the patient performance status, will be using different kind of agents. Now, the concept of minimal residual disease is very important in acute lymphoblastic leukemia, because this tells us that this kind of patient more likely going through a relapse. So it's very important to put a patient into minimum residual disease. It means that I don't want any detectable leukemic cells in the bone marrow. For relapse, we have different agents. The most important one that I want to touch base on is nilarapine, which mainly approved for patients with T cell after failure of 2 lines of therapy. Inotuzumab, which is a new monoclonal antibody that targets anti-CD22, has an excellent complete remission for such patients, and patient can go for a transplant afterwards, along with blinatumomab, which is anti-CD19 directed toward CD3. This is an excellent medication to put a patient into minimum residual disease and take him for a transplant. The last agent that I wanted to touch base on is an immune therapy, new adapted or newly developed, in which called chimeric antigen receptor, or called CAR T cell, Chimera mainly, which is the product approved for patients with acute lymphoblastic leukemia. We take the patient's T cell, we modify them genetically, and we reinfuse them, in which the T cell of the patient will start recognizing leukemic cell and kill them. Now, the most important, or the black box warning with CAR T cell in general, is cytokine releasing syndrome. I'm going to skip the case. The patient usually present with fever and with desaturation or decrease in the respiratory rate. These patients needs to be recognized as soon as possible to be treated with certain medications such as interleukin-6 inhibitor, tocilizumab, and to support the patient with corticosteroid to prevent death. And according to the risk factor, we treat. Another most common side effect associated with CAR T cell is neurotoxicity or encephalopathy. Those kind of patients also might be benefit from steroid, tocilizumab, and supportive care. And thank you very much.
Thank you, Dr. Hadil. Thank you for this very informative presentation and to the point presentation. MashaAllah, you summarized the acute myeloid leukemia and acute lymphoid leukemia. Thanks a lot. So now, looking for a question from the audience. If you have any question, you can type it. I think we are done, Dr. Hadil. So thank you. Thanks a lot, Dr. Hadil. Now we are going to start our second presentation, which is chronic leukemia. This will be presented by Dr. Abdullah Rajhi. He is a PGY2 Oncology Hematology Clinical Pharmacy resident and in King Faisal Specialist Hospital and Research Center. Welcome, Dr. Abdullah, and you can start now. Good luck.
السلام عليكم جميعا. معكم عبد الله راجحي. And inshallah today we'll talk about chronic leukemia. So hopefully inshallah you will learn something about it. So the outline inshallah that I'm going to talk about it, a little bit of introduction, وبعدها راح أتكلم عن chronic myeloid leukemia, and then I'll talk about the chronic lymphoblastic leukemia. So the goal of this presentation, طبعا my goal is you guys have to have only basic understanding اللي هو CML, CLL. I'm not going to go through deeply into the treatment. So I'm going through the basics so you guys can have an understand of the two diseases. So طبعا as you heard in Dr. Hadil's lecture, you understand that the leukemia can happen واحدة من اللي هو two lineage. إنه it originates من ال blood stem cell. It can go مثلا اللي هو myeloid or can happen in the lymphoid. الفارق بين اللي هو acute leukemia and the chronic leukemia is the difference اللي هو progression of the disease. For acute leukemia, you have to act fast, and within weeks, if you didn't treat that patient, he will die. However, for chronic leukemia, the difference is that the progression of the disease is slower, so the patient might live longer, and you don't need to act as fast as possible as you can do for acute leukemia. So that's some of the differences of between an acute and chronic. So let's talk about chronic myeloid leukemia. So خلينا نبدأ أول شيء بالcase. So our patient اللي هو 42 years old presented to the clinic, جات علشان physical examination. She did اللي هو her blood work. شافوا إن WBCs كانت about 94,000. والplatelets of 197,000 والhemoglobin عندها 13.1, so normal in this case. Her serum chemistry كانت normal. طبعا بعد ما شافوا WBC they referred her to hematology. Hematology requested a bone marrow biopsy, and they found that it was notable for marked hypercellularity. They did the cytogenetics وشافوا إن عندها translocation 922. So that confirmed a diagnosis of chronic phase CML. And so the patient is considered intermediate risk according to her SOCA score. So what do you think that's the appropriate initial therapy for this patient? Imatinib, dasatinib, or ponatinib, or allogeneic stem cell transplant? So we can conclude. So mostly said imatinib. So we'll look into it right now. Just like quick statistics about اللي هو CML. طبعا في اليونايتد ستيتس تقريبا about 8,000 CML cases happened in 2016 والميديان age حقتها كانت تقريبا about 64. طبعا هنا في السعودية كانت around 100 patients were diagnosed with CML في 2015 based on the schedule اللي تشوفونها من هنا تقريبا من chronic myeloid leukemia. You can see the numbers over here تقريبا 199 patients were diagnosed in 2015. طبعا الفكرة في ال CML اللي هو إنه ال patient will have a bone marrow hyperplasia and then it will accumulate of differentiated myeloid. المyeloid will be accumulating في اللي هو peripheral blood. بعدها راح يكون في rapid accumulation في البلاست cells وفي البون مارو and that will suppress اللي هو normal hematosis. So the production حقت اللي هو red blood cells, the platelets, all that will be suppressed. But these patients will have اللي هو anemia, thrombocytopenia, and that may lead him to death. So الباثوفيسيولوجي طبعا في الليكتشر حقت الدكتوره هديه we mentioned انه اللي هو something called اللي هو Philadelphia positive في البيشنت اللي عندهم ALL. So الفكره في انه البيشنت في CML the hallmark للCML هو الفيلادلفيا positive. تقريبا 95% of the patient will have a Philadelphia positive. الفكرة إنه ال APL طبعاً في كروموسوم 9 وكروموسوم 22. ال APL اللي هو البروتين اللي موجودة في الكروموسوم 9 will be translocated to join اللي هو ال PCR protein في الكروموسوم 22. And that will create اللي هو ال PCR APL. And this creation of the PCR APL will lead to continuous cell proliferation. The patient will lose اللي هو our cells will lose the ability to apoptose. فبيكون عندنا very accumulation of اللي هو cells. طبعا وش الclinical presentation? Signs and symptoms or physical examination. The patient most of the or 50% of تقريبا 40 to 50% of patients will be asymptomatic. يعني يروحون اللاب, they did the CBC, they found that they have اللي هو high WBC or اللي هو low platelet. ممكن patient they come with اللي هو fatigue, left upper quadrant pain, abdominal pain or distension, أو إنه they have اللي هو B symptoms, weight loss, اللي هو night sweats. They will come maybe with اللي هو splenomegaly or hepatomegaly. في اللاب abnormalities, as we mentioned إنه يكون هذول patient عندهم high WBC, so leukocytosis, ال LDH تكون عندهم أيضا عالية, ال high uric acid زي ما ذكرت الدكتورة هديل في ال presentation إنه because the rapid turnover of اللي هو cell that possibly increases اللي هو ال uric acid. The patient also, على حسب the phase that they will have, they might have اللي هو low or high platelet. High platelet can reach about 1 million, or low platelet in يعني تقريبا 30 or 20s. But how do we diagnose these patients? So diagnosis, the first thing is, as you saw في الcase, إنه we do اللي هو CBC with differential. We do then after that, if we saw مثلا في increase في WBCs, لازم الآن we arrange مثلا في اللي هو biopsy, bone marrow biopsy. If we did the bone marrow biopsy, that will give us some confirmation that the patient might have اللي هو CML. البيشنت السيتوجينetics and molecular genetics هذا عشان نشوف إذا كان عندهم الفيوجن أو اللي هو PCR APL ونتأكد إنه البيشنت they have اللي هو CML. طبعا ممكن حتى نشوف اللي هو رول حقت الإيميجينج اللي تتشيك اللي هو CT to detect إنه إذا كان في disease affecting other organs. زي ما قلنا إنه patient ممكن they will have splenomegaly or hepatomegaly. what will happen after that؟ طبعا بعد ما ناخذ له البايوبسي، بعد ما نشوف المولكيولر all that will check نقول نحط البيشنت في which phase. هل هو في الكرونيك phase؟ هل هو في الاكسلريتد phase؟ هل هو في البلاست كرايسيس؟ طبعا اذا كان في الكرونيك phase لما نسوي البون مارو بايوبسي نشوف انه there is 10 about 10 less than 10% موجود في البلاست او اللي هو الاماتشور سيلز موجوده في البريفرال بلاد او في البون مارو. بس بالنسبه لما نقول انه البيشنت والله انهم accelerated phase معناه انه ممكن يكون عندهم راح يكون عندهم about 10 to 19% of البلاست في البريفرال بلاد ولا موجود في البون مارو. والبليتلت usually less than 100,000 or more than 1 million. And they will have a progressive اللي هو splenomegaly. البلاست كرايسيس طبعا this is if العدد البلاست اللي هو more than 20%. طبعا if patient have a blast crisis you will treat him as انه you treat ال AML وال ALL as يعني زي ما ذكرت الدكتور هتيل في her lecture. So how do we treat it? So قبل ما تبدا التريتمنت لازم تعرف هل هو البيشنت في السي ام ال هل هو عندهم البيشنت عنده chronic phase ولا accelerated phase ولا blast crisis. الشيء الثاني هل هو عنده any other conditions يعني هل هو عنده heart failure هل هو عنده diabetes because we know these medications اللي راح نستخدمها they are very toxic so we want to make sure انه the medication that he's and the medication that we're going to prescribe for him is suitable for his condition. طبعا if the patient on any other medications طبعا if the patient on any other medication you have to check اللي هو drug interactions because the medication that we are using for CML they do have significant drug interactions so we have to measure for that to look for that. الشيء الثاني انه you have to look into والله هل البيشنت عنده specific mutation في عنده some genetic abnormalities. اذا كان عنده certain medication اذا كان البيشنت عنده certain mutations you cannot give him this medication. That's very important to see. الآخر شيء هل البيشنت do you think the patient will be compliant to the treatment? لأنه this is a major or very important role a very important factor and the patient should be compliant to the treatment. And if the patient was not compliant he will lose the response to treatment and if he lost the response to treatment means that you have to try another medication and that may affect his survival للpatient. So التريتمنت طبعا if مثل ما ذكرنا في البدايه انه if CML او اللي هو chronic leukemia is a slowly progressive so but if you didn't give him any treatment the CML will be يعني lead to fatal outcome within 5 years. your goal من التريتمنت is to eradicate of اللي هو leukemic clones من البون مارو. هذا you can do it only by a bone marrow transplant. But usually we don't go with bone marrow transplant at the beginning. When we usually leave it at the end if we took all the treatments or the patient took all the lines of therapy. النقطة الثانية أو another goal اللي هو maintenance of the chronic phase with minimal toxicity of treatment. هذا اللي هو احنا usually we stay with. إنه to give him medication to keep him على chronic phase و prevent him from going مثلا from an accelerated phase أو اللي هو blast crisis و improved اللي هو survival حقت البيشنت. فusually الفيرست لاين treatment اللي هم tyrosine kinase inhibitors as soon as the patient diagnosed with CML. طبعا not as soon but you can base it based on the patient risk factors and other factors that we're going to talk about. The medication that we actually use it for now is مثلا عندكم الإيماتينib, الديزاتينib, البوزاتينib, النيلاتينib, بوناتينib and amcitaxane. طبعا مثل ما ذكرت إنه those patients if they failed all line of treatment they can offer اللي هو bone marrow transplant. طبعا if you looked into هنا ذكرت انه treatment is based on the risk score اللي هو SOCL or Hartford. SOCL score one of the scores that we're using, and that takes and طبعا it's only exclusively for CBL, and it looks into اللي هو age, how much or how big is the spleen, and the platelet count, and then the myoblast or اللي هو blast. And then based on it, you will consider a patient low risk, ولا intermediate risk, أو high risk. على حسب السكور اللي that will you will get from calculating from the SOCL score. طيب بالنسبة للchronic phase, so في الchronic phase اللي هو low risk, إذا كان البيشنت بعد ما حسبنا اللي هو low risk, إذا كان you can start him with imatinib, and that considered as a preferred therapy. لكن if the patient have intermediate to high risk, you will give him usually we start with dasatinib. If he failed, you go with bozatinib, nilotinib, and others, but not ponatinib as like the first line treatment. If the patient have اللي هو accelerated phase, هنا you can treat him as اللي هو اللي عندهم intermediate or اللي هو high risk. بس in plus phase طبعا as you guys remember, you treat it as AML or ALL زي ما ذكرت في الدكتورة هذه lectures. وطبعا you monitor these patients على حسب اللي هو PCR APL clones في اللي هو using اللي هو cytogenetics. ف you can use اللي هو quantitative reverse transcriptase اللي هو PCR, check how the patient responding. And then you follow the percentages. Usually what we're looking for is less than 1%. So hopefully, we achieve always, we want to achieve less than 1% within the first 3 months. And this is how you follow, how do you know if the if the patient is having a resistance to the tyrosine kinase or لا, على حسب اللي هو PCR APL. طبعا as a pharmacist you have to know to consider while filling اللي هو medications. So the first thing is هل في drug interactions? With this medication they do have a lot of drug interactions مع البروتين pump inhibitors, مع H2RA, مع الانتي-acid. If they took it together, that decreases اللي هو efficacy of most of the TKIs. Antidepressant, not all, with azoles, هذول increases اللي هو exposure حقت TKIs. And مثلا عندكم الفلوروquinolones also increase the risk of اللي هو QTC مع TKIs. And those TKIs have an increased risk of اللي هو QTC. طبعا patients, if they have any side effects, so like cardiotoxicity, rash, edema, do we have to adjust their doses? Do we have to do that? That's something that you want to look into when filling these medications. And of course, you want to check if the patient compliant with medication, and you also want to make sure that the patient is taking the medication right. هل هو ياخذها مع الفود, without food, an empty stomach, all that, because this medication, الeffect حقتها can be الefficacy can be affected by food, the presence of the food or without food. وطبعا you can know اللي هو loss of response based on either shifted PCR APL is increased by at least 0.1% or على حسب اللي هو الكرايتيريا. And these the method specific mutations that you can see, and you'll know that the patient, if the patient develop a mutation or no to this kind of thing. If the patient method, for example, if the patient have a mutation in T315I, that you cannot give him pozatinib or dasatinib or even nilotinib, and you can give him ponatinib, for example. So going back to our case, so we can show the result, the previous result. Most of you answered was imatinib. However, because the patient have an intermediate risk, usually we love to go with, we usually go with dasatinib. Ponatinib is something that you would not consider at the beginning because of that you can use it for if the patient develops specific mutation. So an allogeneic stem cell transplant is not something that we offer at the beginning. Imatinib, because we prefer it in the low risk, we don't prefer it in the intermediate risk. The second section, اللي هو chronic lymphoblastic leukemia. So this is the case. So FP is 63 years old and well-controlled atrial fibrillation, hypothyroidism, hypercholesteremia. He noted significant painful lymph node. His family medical doctor prescribed antibiotic, then resolved. He returned. His CBC was having lymphocytosis. Flow cytometer confirmed diagnosis of CLL stage 2 with normal cytogenetics. What's the best treatment for this patient? And you can see that the patient is having fludarabine, rituximab, ibrutinib, or VCR, or almatuzumab rituximab. And we can just go over the whole answer. You can, so the answer is VCR. So we'll go through it now. So for statistics, طبعا اللي هو CLL in Saudi Arabia, about 63 patients were diagnosed with CLL in 2015. I'm not going through the other statistics because of the time. Pathophysiology, طبعا CLL, it's not like CML. There is no common genetic target. However, we do have a target في هو PTK. It's extremely crucial for the activation of several constant active pathways of CLL, and that will improve survival. It's similar to CML in it's an underlying course. So a patient usually you don't have to act fast as you do with ALL or AML. But you have to start treatment if the patient is symptomatic. Signs and symptoms, usually fever, fatigue, weight loss. Those patients, similarly to the CML, they usually have a splenomegaly, hepatomegaly, and then it shows also hypercellular, increased mature lymphocytes. They have an increased megakaryocytes. So that's some of the things that you will see with CLL. A staging of CLL is based on the array system, which takes the CBC-D, which لازم تشوف فيها اللي هو enlarged nodes. You have to look into اللي هو splenomegaly والhepatomegaly. وبased on it راح نشوف اللي هو you can do اللي هو السكورينج. هل هو سكور في stage 0, هل في stage 1, 2, 3, or 4. طبعا في certain patients بعد ما after they diagnosed with CLL, they have what we call Richter's transformation. In this case, the CLL will be transformed to something called to a lymphoma, and that would be على حسب the patient's risk factors. When lymphoma usually happens, it's either Hodgkin or non-Hodgkin lymphoma. Treatment, طبعا before you start the treatment, you have to understand where the patient is, which stage. Is there specific cytogenetics abnormalities? It will change the path of treatment. Age, and very important, especially if they are less than 65 or more than 65 years old. And comorbidities that can be worsened by treatment, very important. And if the patient is asymptomatic or symptomatic at presentation. طبعا the goal, similar to CML, is you want to achieve and maintain remission with minimal treatment-related toxicity. Treatment in this case على حسب اللي هو array staging. إذا كان البيشنت between اللي هو array stage 0 to 2, if there's no indication, which is I'm going to talk about it in the next slide, then you can observe. But if there is a treatment indicated, you can start therapy على نفس اللي هو array stage 3 or 4. طبعا stage 3 and 4, you will look into اللي هو cytogenetics إذا كان patient more than 65 or less than 65, and if the patient is frail. طبعا if you guys looked into the NCCN guidelines, mostly they will say in a patient ibrutinib is the preferred option إذا البيشنت ما عنده deletion 17B or TB53 mutation. بس إذا كان البيشنت عنده deletion 17 or TB53, then in this case you could go with acrabrutinib or ibrutinib or venetoclax مع الابnituzumab. Rectal transformation, you can treat it as lymphoma as mentioned, and you will see it inshallah with Dr. Aisha's lecture. The hematopoietic stem cell, as we said, can offer cure, but it's not the first thing you want to do for these patients. And طبعا indications for treatment, طبعا if the patient have any B symptoms اللي هو severe fatigue, unintended weight loss, threatened organ function, إذا كان patient عنده bulky disease, especially if they have a splenomegaly or lymphadenopathy, إذا كان عنده progressive bone marrow failure, إذا كان patient عنده anemia, thrombocytopenia, or if they do have اللي هو autoimmune anemia or thrombocytopenia that is not responding to corticosteroid, أو إذا كان an absolute lymphocytes count more than 200,000. And then the last thing is إذا كان عنده symptoms of leukocytosis, and that's the things where you can start treatment for a patient اللي عندهم RAY stage 0 to 2. And you monitor the response based على اللي هو الجروب A والجروب A. طبعا الجروب A اللي هو what we call the major response, and the B is a minor. So A is the lymph nodes, liver, and spleen size, and the last one is the circulating lymphocyte count. الجروب B اللي هو CBC والplatelets, الbone marrow biopsy, and neutrophils is normal without any need for growth factors. وعشان نعرف إنه patient is responding to treatment, نشوف إنه if they have a complete remission, if they a complete remission is all these are improved. partial remission مثلا نشوف إنه ثنتين من اللي هو البارامترز في الجروب A واحدة من البارامترز في الجروب B is need to improve, so that means that the patient is in partial remission. The only thing I'm going to talk about for treatment اللي هو ibrutinib. Ibrutinib طبعا because it's a major medication that في CLL, so I'll just quickly talk about it. طبعا اللي هو ibrutinib it binds to اللي هو BTK enzyme. احنا ذكرنا في CLL انه BTK plays a major role في ال CLL. ibrutinib binds to the BTK enzyme, inhibits signaling, and that will inhibit اللي هو tumor cell proliferation migration. طبعا dose that you usually give is 420. Unique toxicities about ibrutinib اللي هو transient lymphocytosis, and that you will see immediately after you start ibrutinib. If you saw that, you would not do anything regarding any treatment. That's something that we usually see with ibrutinib. In patient اللي طبعا one of the problems is the risk of bleeding, and that's something that we usually afraid of when we use ibrutinib. خصوصا if the patient have comorbidities that require him to receive aspirin, clopidogrel, all that. And the most important is the atrial fibrillation. تقريبا about 6% of patients or 7 will develop atrial fibrillation because of ibrutinib. So major drug-drug interaction, usually with 3A4, it's very important that you do dose modifications. So we'll just, this is not right, and I put it in red. It's actually the third one, اللي هو VCR, and that is because the patient have an atrial fibrillation, so that possibly might worsen the treatment, but that again may it's preferably to use LVCR for this patient rather than using ibrutinib for him. And thank you.
Thank you, Dr. Abdullah. Thank you for this to-the-point presentation. We learned a lot, especially you talked about the medication, drug-drug interaction, and medication adverse event, which is really, really very important talk. Now for question, if you have any question, you can write it down in the chat.
I do have a question. Oh, thank you. Is there a reason as why bone marrow transplantation is used lastly? So the problem with bone marrow transplantation is it's not an easy process, and it's usually extremely toxic. And also the other issue is that with bone marrow transplantation, sometimes you do not predict that the patient will even success with it. So what we do usually to maintain a patient على actual therapies and prolong his survival. We don't know if the bone marrow transplantation might lead to even worse disease. So it's for us, because it's extremely toxic, we prefer to usually put it as last. Even though it can offer cure, لكن the possibility of offering cure is not extremely, the percentage is not extremely high in these cases. Should we DC the medication when the patient develop atrial fibrillation? So in this case, what we usually do is usually it's how to say this, it's usually preferred to, if the patient develops atrial fibrillation, to stop the medication, but it will be up to the physician. So either to decrease the dose or possibly consider either to decrease the dose or holding the medication and see if the atrial fibrillation actually improved. Yeah. Okay, I think we don't have any more answers. Any more questions?
Yes, I think now you answered the two questions in the question and answer. So thank you, Dr. Abdullah, for this presentation. It was very informative presentation. And now we can go for our third and last presentation, which is about lymphoma, which will be presented by Dr. Aisha Al-Azmi. Dr. Aisha is PGY2 Oncology Hematology resident in King Fahd Medical City in Riyadh. Welcome, Dr. Aisha. You can start now, and good luck.
السلام عليكم ورحمة الله وبركاته. دكتور عبد الرحمن، الصوت واضح؟
واضح دكتورة، واضح. تفضلي.
طيب، السلام عليكم ورحمة الله وبركاته. Today, inshallah, we'll talk about lymphoma. Today's talk will be very basic. We'll start with about what is lymphoma, and then we'll have some point we'll focus about the pharmacy practice. So I am Aisha Al-Azmi, BGY2 Oncology Hematology resident, and inshallah we will enjoy for the next 30 minutes bidnir Rahman. So for the outline for today's talk, it will talk about what is lymphoma and what most frequent type of lymphoma, what kind of treatment that we offer to our patient, and then we have finally how we can improve the patient outcome, and we'll focus on some pharmacy practice fields. So hopefully, I think our colleagues, thankfully, they talk about the cancer treatment and different kind of disease. And you know that the bone marrow or the stem cell started from the stem cell, and the stem cell will be divided into two major groups, like the myeloid and the lymphoid. So after division to the myeloid and lymphoid will be subdivided again to, for example, in the lymphoid system or with the common lymphoid progenitor, to small lymphocyte, and then to B lymphocyte, and to T lymphocyte, and to the natural killer. The same goes with the myeloid progenitor. It will be subdivided into megakaryocyte, erythrocyte, muscle, and myeloblast, and so on. So at any stage, if there is any abnormality or loss of function or deletion, the patient will end up with a disease or abnormal cell. So today's talk will be focused in the lymphoid system, and mainly we are talking about the mature one, which is the natural cell, natural killer cell, T lymphocyte and B lymphocyte. I just want to emphasize that lymphoid system is present the whole over the body. You can find it everywhere in the body. That's why lymphoma as a disease is multi-system, involved multi-system, multi-organ, and you can find it in everywhere, and there is so many classification. But for today's talk, it will be very basic. We'll start what is lymphoma, and I will highlight the kind of treatment that we offer to the patient. So if we talk about lymphoma, we know that if there is any abnormality with the division of the cell from the lymphoid system, we'll end up with heterogeneous group of malignant neoplasms, especially for the mature lymphocyte that inhibit primarily the lymphoid organs. And we saw that the lymphoid system involved almost the whole body or organ of the body. We've emphasized that with varied pattern of clinical behavior and response to the treatment. So we are talking about a group of disease rather than a disease, one disease entity. Patients usually end up with adenopathy followed by cytopenia, and this is the most common presentation of the disease. And patient may also present with constitution symptom like a B symptom, and this is B symptom very specific for a lymphoma and can be found for other disease, I mean as a term. And if patient presented with a B symptom, usually it will be as a poor prognosis. What is B symptom? B symptom mainly focus on three symptoms like unexplained weight loss. Some literature they mentioned that weight loss more than 10%, or patient presented with high fever and drenching night sweats. This is the most commonest symptom that patient will be presenting if they have a lymphoma, or it could be also associated with other disease. Sometimes patient may be presented with pain due to enlargement in the lymph node, and other patient may present with painless lymph node enlargement. Chronic pruritus have been reported as well, with other non-specific symptoms, for example, shortness of breath and chest pain, especially if the tumor presented in the mediastinal mass. So it will be complex the diaphragm, and the patient will end up with some respiratory symptom. So talking about the etiology, so far there is no exact etiology, but a lot of literature they mentioned that the risk of developing lymphoma largely connected with infection, especially per se EBV infection that have been found in 40% patients with Hodgkin lymphoma, and H. pylori patients with gastric lymphoma disease as well. Autoimmune disease also have been found. Some patients with autoimmune may develop lymphoma as well. Immunosuppression, either as drug related to immunosuppression, or as a disease like, for example, HIV. Drugs, for example, like alpha necrotic factor or chemotherapy as well. Pesticide and herbicide, especially this kind of pesticide and herbicide, be connected with abnormality with translocation 1418 that usually positive in non-Hodgkin lymphoma patient. And some patients who have Hodgkin lymphoma may have a familial or a family history with a disease or the cancer disease. So these factors may increase the chance of patient to get a lymphoma of any kind. So lymphoma, as we mentioned, it is group of disease. So the classification mainly rely on the WHO classification of the tumors of hematopoietic and lymphoid tissue or lymphoid tissue. And it will divide it into two main classes: non-Hodgkin lymphoma and Hodgkin lymphoma. And the median age for patients who presented with non-Hodgkin lymphoma is around 65 years, while patient, especially a pediatric patient, may presented with a high-grade lymphoblastic lymphoma and Burkitt lymphoma. This is most common in pediatric, but still some adult patients also, or younger adult, may have this kind of disease. While Hodgkin lymphoma is biomiddle age distribution, it may strike at the age of 15 to 34 years, and another strike if in the elder age, like in more than 60 years. And this is why, because as we mentioned, lymphoma is a group of disease. Some of these diseases under lymphoma, it's slow growing. So basically may have lymphoma, but will not have a symptom unless later in the stage of the disease, like patient presented with later stage. So it will take time, especially with indolent subtype of lymphoma. It's predominant in the male. And for Hodgkin lymphoma patient, usually they have positive CD13, CD15 expression. And this kind of patient usually presented with normal karyotype and with normal genetic factor. So we mentioned that this is the two main classification of the lymphoma, non-Hodgkin lymphoma and Hodgkin lymphoma. So to differentiate, non-Hodgkin lymphoma usually is, we are talking about the origin of the cell, where the defect or the abnormal function have been originated. So for example, in non-Hodgkin lymphoma, it will be abnormal function of the B cell lymphoma, B cell, I mean, T cell or natural killer cell. So any abnormality will be end up with lymphoma disease, and these all categorized under non-Hodgkin lymphoma. The majority of patients presented with B cell lymphoma, like 85%, and would be subclassified because B lymphoma or B cell lymphoma have another subclassification of disease. We can just simply say we have indolent, aggressive, or very aggressive. The same with the T cell origin, it will be indolent or aggressive diseases. While the Hodgkin lymphoma, it mainly depends on the histological subtype. So it means you have to have the biopsy or tissue biopsy should be seen under the microscope, and there is two main classification of Hodgkin lymphoma. I will talk about it in the few minutes. So I mentioned indolent, aggressive, and very aggressive. What does that mean? Indolent means that slow growing tumor cell or neoplasm, and this is the majority of non-Hodgkin lymphoma disease considered as indolent. And because of the slow growing, so patient usually presented in the later stage, and the goal of treatment in this stage, it will be usually palliation. So while for the very aggressive, it means the tumor cell is rapidly growing, and this is almost account for a small portion of patients. And this kind of disease can be cured and treated with chemotherapy if presented or introduced in timely manner. So it will be life-threatening if not treated, or if not treated properly or rapidly. While the aggressive one, it will be also is a rapid growth pattern of the tumor cell, and this is the second most common type of non-Hodgkin lymphoma. And this kind of lymphoma, or the aggressive lymphoma, is curable with chemotherapy. Here, just like simplifying, what is the B cell lymphoma, what kind of indolent or the disease under indolent or under aggressive or very aggressive. The most common one for indolent, we can mention that follicular lymphoma. So if untreated, the survival will take years, while the aggressive one, the most common disease with diffuse large B-cell lymphoma, it will take months to develop. Very aggressive, it will take weeks. So the patient need to be treated rapidly. This is the same goes with the T-cell lymphoma. We have the indolent and we have the aggressive. And with the indolent, the most common type will be cutaneous T-cell lymphoma, while the aggressive will be peripheral T-cell lymphoma. And if this kind of, because it's aggressive, treatment should be introduced within a month of a presentation. So this is like simply talking about non-Hodgkin lymphoma disease. While the Hodgkin lymphoma, we have two main classes, which are classical Hodgkin lymphoma, which represent almost more than 95% of patients with Hodgkin lymphoma. And we have nodular lymphocyte predominant Hodgkin lymphoma, which is very rare or account for less than 5%. So under microscope, if you have the tissue, they will find that a very specific pattern of the tissue, which called Reed-Steinberg cell. This is very characteristic for the classical Hodgkin lymphoma, while for the nodular lymphocyte predominant under microscope, they describe the cell as popcorn. So this is very characteristic for the nodular lymphocyte predominant lymphoma. So we are talking here about histological type of the Hodgkin lymphoma, while the non-Hodgkin lymphoma, we are talking about from where the disease originated. Is it from B cell, T cell, or natural killer? So the classification system, we talk about the WHO classification, but for the staging, we use for the majority of the cancer, not only for the lymphoma, but for the majority of cancer staging, we use Ann Arbor classification staging. And this stage, the classify the disease or staging the disease based on the symptom, based on the involvement of the lymph node, if we talk about the lymphoma. And we have 4 main stages, stage 1 and 2. Usually it's include like 1 to 2 lymph nodes have been involved, and this usually it's early stage, can be cured with some either like waiting watchful period for the patient. If the patient develops symptom, then we can introduce the treatment, or if the patient with the symptom, then you can start chemotherapy for the treatment, or you can give the patient radiotherapy or even by surgical resection. So stage 1 and 2 usually favorable risk for the treatment, while the advanced stage it calls stage 3 and 4. So Ann Arbor classification staging be totally dependent on the symptom. If the patient presented with B symptom or no B symptom, so that's why they develop another classification for staging. They call it as Lugano classification. This is for the staging. Okay, sorry. Okay. For the staging, so I think there is some problem in this slide. So for the classification staging, also there is a 4 stage, stage 1, 2, 3, and 4. This for the Lugano classification, they include the extent of the disease and number of comorbidity the patient may complain in addition to the symptom. So we have to agree on that. For lymphoma disease, the definite diagnosis is surgically excited tissue biopsy. So tissue biopsy is mandatory for diagnosing the lymphoma disease. So in general, in lymphoma, summing up what we talk about, lymphoma, we have 2 main classifications. We have Hodgkin and non-Hodgkin lymphoma. Non-Hodgkin lymphoma will be further classified into T cell and B cell and natural killer as well. While Hodgkin lymphoma, we have another 2 sub-classification with the Hodgkin lymphoma. And for the B cell, because this is the most common disease, 85% patients present with B cell lymphoma, it's sub-classified again with indolent, aggressive, and very aggressive. And you find here what kind of disease that classified under indolent or under aggressive or very aggressive, like for example, Burkitt lymphoma. So there is a risk factor that give us like insight. Should we, insight on the prognosis of the disease and the treatment that we should choose for your patient. So we have favorable stage, especially for stage 1 and 2. The favorable stage 1 and 2 without risk factor, or if the risk factor will be presented, it means unfavorable and patient need like different modality of treatments. So what is the unfavorable risk factor? It will be if the patient presented with bulky mediastinal mass, or if the patient presented with age more than 50s, have high ASR at the baseline or at the based on the presentation of the disease. Patients who have B symptom, as we mentioned that B symptom usually connected with the poor prognosis, and if there is more than 3 nodal sites have been involved. So if any of these factors have been presented with the patient, so this is we can consider as unfavorable risk factor, and we need different kind of modality for the treatment. For if we talk about cancer in general, it means that we have to talk about genetic and molecular testing, and this is applied for all cancer and neoplasm disease. But in general, for lymphoma, we will use the FISH or PCR if involved in the bone marrow, especially if we to check for the translocation or defect for the, or any abnormality in the gene. And we can use cytogenetic analysis, and why we use this kind of testing, because it will help us as a clinician in general clinician, I mean, for the diagnosis, for the pharmacist, as well for the management, and we can identify which patient they are high risk for resistant, and we can upfront change use the appropriate treatment before even start the therapy for the patient. And this is like the list of, I will not go through it. This is the list of some kind of or commonest type of chromosome abnormality or genetic abnormality. And inshallah, you will know that what we are talking about, like translocation, rearrangement, deletion, and defection. Or if you don't know it, we can talk about inshallah, or for sure in this course, someone will talk about it, bismillah. So how we can approach our patient? The approach will be vary greatly, and it's depends in the tumor stage, the type of lymphoma, the extent of the disease, and absolutely we have to consider a patient factor. If patient presented with a B symptom, the age of the presentation, and performance status, and in addition to the regular lab requests like CBC, ASR, LDH, and absolutely liver function test, serum creatinine, with other imaging, especially for the CT scan and bone marrow evaluation, PET and bone marrow aspirate. This is we can use it as approach to choose the initial treatment for your patient, or what is the prognosis for your patient, or how we can change the therapy or the treatment modality throughout the treatment course of your patient. So if you know all these, then we can choose the proper treatment for our patient. Just this, we mentioned that we have Hodgkin and Hodgkin lymphoma. If the patient have a very aggressive disease, it could be curable with the treatment, while if patient will present with indolent disease or with very advanced stage, like stage 3 or 4, it could be treatable, but maybe will not be curable. So how we can decide, again, is depending on the type of lymphoma, what kind of lymphoma we are dealing with, the stage, is it stage 1, 2 with favorable risk, or with unfavorable risk, or advanced stage with 3 or 4. What is the site of lymphoma? For example, patient who presented with CNS involvement, it means that we have to choose different modality with very good CNS penetration. And absolutely, we have to consider patient factor like the age or other comorbid disease. And as a pharmacist, or for any hospital where the treatment we should offer, we have to consider the logistic. If we know the disease, and then we have to check for the treatment. If we have the treatment, then can we offer that treatment? So we have to consider the logistic, as a factor for choosing the proper treatment for your patient. And then absolutely the use of genetic marker, especially for the advanced stage and for patients who with relapse refractory. Modality of treatment is range from radiotherapy until the target therapy. And we can see here for the lymphoma, radiotherapy, sorry, oops. Sorry for that. I think I have a problem with the slide. Hello?
Yes, Dr. we hear you.
Yeah, sorry about this technical problem. So this is the treatment modality. Start with radiotherapy. You can see that radiotherapy have been introduced for the lymphoma treatment back in 19th century, followed by the chemotherapy, and then multiple cytotoxic agents with different mechanisms of action. This is the concept for treating any cancer disease. And monoclonal antibody targeting CD20, this is one of the a huge interest for treating a lymphoma, because we know that the majority of B-cell lymphoma or B-cell expressing CD20. So when we discover the CD20 targeting therapy, it was like one of the improvement اللي هي النقلة النوعية تطور improvement in the treatment of lymphoma. And CD20, if we talk about CD20, it means that we talk about rituximab, and in addition to the commonest chemotherapy for treating lymphoma, especially for CHOP. So when they add rituximab to the CHOP, this is abbreviation for cyclophosphamide, doxorubicin, vincristine, and prednisolone, they found that patients improve the overall survival rate for patients, especially with diffuse large B-cell lymphoma, would increase the complete remission rate and increase the progression disease-free survival. So continue the treatment modality. High-dose chemotherapy followed by the autologous stem cell transplant have been introduced for the lymphoma patient, especially in the relapsed refractory stage, and for the allogeneic transplant also have been offered. With targeted therapy and immunotherapy nowadays is one of the new treatment option for patients with lymphoma. And still the treatment ongoing, discovery of a new treatment for immunotherapy and targeted therapy. And as a pharmacist, we should be like very cautious when we choose the proper treatment based on the patient risk factor, the price, availability, and for absolutely the side effect profile for every medication, for every drug that we choose to treat our patient. So when we choose the treatment, absolutely for early stage, like stage 1 and 2, we can consider radiotherapy, chemotherapy, or even combined therapy based on your patient risk factor. If patients have bulky stage, usually combined therapy or combined modality, either with chemoradiation or chemotherapy followed by surgery, or the vice versa. With the stage 3 and 4, different treatment modality, and here we can introduce the target therapy for treating the advanced stage of lymphoma and relapsed refractory. It's open for the stem cell transplant with the target therapy as well, immunotherapy and other target therapy, I mean. So why we use the chemotherapy? Chemotherapy, we use it either to induce the cell death through apoptosis, and that's why we call cytotoxic, or just to prevent the cell division, and we call cytostatic. And this is the same concept that we apply to the using of an antibiotic for treating any infection. So chemotherapy use also, it can cure the disease, at the same time prolong the survival. It will use as a palliation of the symptom. You can use it to decrease the burden of the tumor prior to surgery, just to shrink the tumor size and then introduce patient to the surgery, or as act as radiosensitizer, because chemotherapy again will shrink the tumor. This tumor will be ready to absorb the radiation therapy, and it will prepare patient as well for the stem cell transplantation, either autologous or the allogeneic type. So this is the chemotherapy classes. This is like a general chemotherapy class, but the most common class of chemotherapy that's being used for lymphoma disease starts with alkylating agents, especially for cyclophosphamide, ifosfamide, anthracycline. Antimetabolite as well can be used, vincalciloid and anti-tumor antibiotic. This is the most commonest chemotherapy class that have been used for every type of lymphoma disease, either Hodgkin or non-Hodgkin lymphoma, with different combined therapy from one class to another. So for lymphoma, we can hear about, we have MOP protocol or ABVD protocol or CHOP protocol. And you can see here, all of these protocols have been introduced long time ago, like MOP protocol. This is introduced to the market 1965 to treat the patient with the lymphoma, and then with the common side effect, nausea, fertility, sorry for the misspell, and can cause secondary leukemia. And for 1975, ABVD have been used or introduced to treat Hodgkin lymphoma, and this is one of the standard or the gold standard for treating Hodgkin lymphoma. ABVD is abbreviation for adriamycin, which is doxorubicin, bleomycin, and vinblastine with the carbazine. Every drug has its unique side effect. Like for example, for the anthracycline as a whole or as a class, and doxorubicin in specific, because it's the most studied drug, cardiac toxicity is the most common side effect, while neurotoxicity is attached with vinblastine. CHOP is one of the standards of gold for treat non-Hodgkin lymphoma, and CHOP is cyclophosphamide, doxorubicin, vincristine, prednisolone. The common side effect will be cardiac, neurotoxicity, nausea, and leukemia, especially as a secondary leukemia. And targeted therapy is dependent, as we mentioned. Majority of lymphoma disease is B-cell originated, and B-cell is overexpressed with the CD20. So that's why monoclonal antibody therapy that targets CD20 is one of the best targeting therapy to treat lymphoma. So we have rituximab, obinutuzumab, ofatumumab. This is one of the new CD20 target drug. Again, we have another target therapy like CD30 with the brentuximab and CD52 with alemtuzumab, immunotherapy with PD-1 inhibitor, especially for Hodgkin lymphoma, and CAR T-cell nowadays have been introduced for diffuse large B-cell lymphoma. And absolutely, for any treatment, we are seeking for the cure, but there is no treatment with that price. And the price that we have to pay is the complication. So the complication we are talking here about is, for example, like radiotherapy, patient will end up with cardiac disease. Anthracycline, we mentioned also cardiotoxicity, especially with the cardiomyopathy. Bleomycin means patient may develop pulmonary disease. Alkylating agent is very attached with very good reporting system with a patient may develop secondary myeloid syndrome or acute myeloid leukemia. And the other cancer can be developed like lung cancer, breast, soft tissue sarcoma, infertility, infectious complication, depression, peripheral neuropathy, or disturbed sexual function. And why this complication is very important to be discussed with the patient, because now we know that patients with cancer, they survive longer. This means patients survive, they cure, so they will carry the toxicity later on, especially if we talk about pediatric patients who receive, for example, a Burkitt lymphoma treatment, maybe by the age of 30 or 40, they will end up with one of the cardiotoxicity because of use of anthracycline back in their childhood when they treat the cancer. So to reach the best outcome of the treatment, interprofessional team should be work together. And we know that lymphoma is largely dependent on the histological characteristic, the stage, the presence or absence of prognostic factor. And we know that the goal of treatment patient is to cure. If we couldn't cure it, then we have to control the short and long-term complication. As a pharmacist, we have to educate the patient about the drug benefit, side effect profile, and the pharmacist has to be ensure the patient understand the recommended pre-operative workup before dispensing any drug to the patient. And for us as a working pharmacist and for the future pharmacists, we have to promote the pharmacist's role in well-coordinated care and involvement in the survivorship program. So by this, I will end up my talk. It's very basic about lymphoma. Hopefully, you will get some information about lymphoma and how we can approach the patient. And lymphoma is a heterogeneous group of disease, and every drug have its own chapter. But inshallah, you will have the opportunity in the near future to dig more about the disease, the treatment, and side effect. Thank you very much. And it's open for you if you have any question.
Thank you, Dr. Aisha. Thank you. Thank you very much. It was a very informative presentation, and you touched the most important part and the principle of treatment of lymphoma. Now, time for a question. If you have any question, you can write it down in the icon of question and answers.
So do you have any question?
Dr. Aisha, I think we have a question here about chemotherapy causing lymphoma. There is a question from Zainab. Can chemotherapy cause lymphoma?
Oh,
And
yes.
another question, yeah, from the same audience, how the cancer patient avoid the chemotherapy cause lymphoma?
So answering for the first question, can chemotherapy cause lymphoma? Unfortunately, yes. There is very good reports, especially patients who develop non-Hodgkin lymphoma or diffuse large B-cell lymphoma secondary to use of chemotherapy, especially if patients use chemotherapy combined with radiotherapy. So can we avoid this? We can't predict how we avoid, but we can limit the risk for developing a secondary cancer or secondary lymphoma, especially like reducing the intensity of chemotherapy. Nowadays, there is a talk reducing the number of cycles, because for lymphoma patients, usually the cycle is range from 6 to 8 cycles as initial, and then some patients may end up with up to 16 cycles of chemotherapy. So nowadays, there is a talk and a couple of reports to shorten the treatment course of lymphoma or the cancer, especially if we talk about alkylating agent. Alkylating agent is one of the commonest chemotherapy class that the patient who use it may develop cancer, secondary cancer, like lymphoma, leukemia, and for radiotherapy, patient will develop either as secondary leukemia, or patient may be just present with the whole new disease like lung or breast cancer or so on. So how we can prevent it as a pharmacist? Maybe we can just be involved in the clinical trial. Does the patient who receive less number of cycle of chemotherapy do well as patient who receive like 6 or 8 cycle of chemotherapy? But this one still we can't have a conclusive answer to this question. But it's a very good question. Thank you for question. Hopefully I answered very well.
Thank you, Dr. Aisha, for answering this question. Clear answer. Any more question from the audience? There is a question from Nawal Rabi. How long approximately the patient with lymphoma will get rid of the complications?
So just to make sure I get your question correctly. So your question is how long?
Yes, how long approximately the patient with lymphoma will get rid of the complications?
So unfortunately, as you mentioned, a complication we're talking about here, there is therapy-related complication and we have disease-related complication. If we talk about therapy-related complication, we have a short-term and we have long-term. Short-term, it means that patient while ongoing in therapy. Long-term, it means that after 1 year finishing the chemotherapy. So how we can get rid? it's not like get rid, but we can properly prepare the patient to face by education to face what kind of side effect we are talking about or complication. The most commonest side effect or complication that we can prepare and prevent it, like for example infertility. This is one of the commonest complication with chemotherapy. So talking to the patient before even start the chemotherapy about the infertility and reservoir for the whatever, the sperm or the ovary for the female. This is one thing. The other thing is the cardiotoxicity. Cardiotoxicity by the proper management, like this is the rule of the healthcare provider and the pharmacist. For example, if you use anthracycline, you have to limit the cumulative dose of anthracycline, limit the number of drug-drug interaction with chemotherapy, especially when talking about target chemotherapy and immunotherapy. And put the patient in the surveillance program. So what is the surveillance program? This surveillance programs mean that survivorship program for patients who finish chemotherapy and survive the cancer. So they are cancer-free after finishing the chemotherapy. If we have this kind of program, it is very, very, very well known in US, in Canada, and even in Europe. But in Saudi Arabia, still, it's in developing stage. So once we have a complete full program, survivorship program for the patient who survived the cancer, then absolutely we can catch the problem before patient even develop the complication in later stage. So this is, I think, the answer of your question for how long patient can get rid. We cannot get rid, but we can close monitor the patient with proper program, with coordinated care pharmacists, physician, and nurses, quality improvement, medication safety, and all these specialty. So what's the other question, Dr. Abdurrahman?
Other question. Could you please explain the main difference between non-Hodgkin and Hodgkin lymphoma?
So to differentiate between Hodgkin and non-Hodgkin for lymphoma, as a pharmacist, maybe we don't have very good role in that, because the differentiation, it's in the diagnostic stage. But anyway, non-Hodgkin lymphoma, we are talking about the origin of the disease. Is it B cell, T cell, or natural killer? While the Hodgkin lymphoma, it's under microscope. So they will take the tissue biopsy and they go to the histopathology lab under microscope, and they will see the special characteristic of the tissue. If there is red spring cell, this means the classical. If there is like popcorn, it means that there is a nodular. So this is the Hodgkin lymphoma based in the lab diagnostic. We cannot differentiate based in the symptom. We cannot differentiate by the simple lab, like just withdraw the lab and so on. But this is the most common one. In addition, maybe there is some differentiating between the genetic marker, because usually patients with Hodgkin lymphoma, they present with normal karyotyping and normal genetic profile. They are less sensitive maybe to the rituximab. So rituximab usually you find it in non-Hodgkin lymphoma stage, although nowadays they mention that all lymphoma patients may benefit either the expressed CD20 or no CD20 expression. But this is the most common differentiating between the two diseases. It's mainly at the diagnostic stage. So, but as a pharmacist, maybe we don't have that very good rule for differentiating, at least in the treatment. In the treatment wise, it will be like choosing the chemotherapy. So, for example, I mentioned CHOP. It will be the standard of care for patients who use for non-Hodgkin lymphoma, and ABVD is one or standard of care for patients with Hodgkin lymphoma. And this is dependent on the site. You have to know from where the disease originated, how many lymph nodes involved, the stage of therapy, and so on.
Thank you, Dr. Aisha. Was a very clear and comprehensive answer. Thank you very much. I think for now we are done. Thank you very much for our audience today. And I would like to thank our speakers, Dr. Hadil, Dr. Abdullah, and Dr. Aisha. Thank you very much. It was very helpful and informative presentations. So see you inshallah tomorrow, our last day day 5. We have an interesting topics tomorrow. So see you tomorrow, inshallah. Thank you all.
يعطيكم العافية.